Okay, we are here, gathered today, with the contents of Barry Town's Cureplex? Yes.
Cureplex Field Cric Kit.
Cric Kit.
With ET tube.
With
Here
ET
you
tube.
have your whole ass ET tube.
No swearing. Okay, here it is.
Here you have your ET tube.
Uh-huh.
Your Cric hook, meat hook, which came in this handy dandy little box. A mask, cool. 10cc syringe, scalpel, iodine prep pad, some gauze, and your tube restraint system, which is just a strap with some holes on it.
Mm-hmm. And we know that Cric can be done with just a scalpel and just a tube. 5560, something like that. Oh, that's neat. Okay. Ezra and I
This is interesting. It goes around.
have not prepared or coordinated any of this video, so we're kind of winging it. And that's intentional because if somebody needs a Cric, we don't really have time to kind of prepare it in real life. So Ezra's going to get that stuff ready while I talk about a couple of things with this person. So I uploaded a video of an actual Cric, and a couple of things that weren't mentioned in that video that are worth mentioning in this one is that a lot of people think of Cric as being like this. You have all your basic airway, NPA, OPA, BVM, non-invasive positive pressure ventilation, endotracheal tube, supraglottic airway, video laryngoscope, RSI, all of that stuff. Nasotracheal intubation, and then for some reason people kind of put Cric over in this emergency crash airway algorithm. I would encourage people to put Cric as part of their airway algorithm and not as like a separate crash airway. Just put it as the last step in your airway algorithm. That way it's not a surprise if you get to it. So that's one thing. The second thing is I encourage the use of a bougie, especially if your patient is smaller. These kits do not come with a bougie, do they?
No, they do not.
No, they do not. The second thing, and some of this is just my opinion, and we do have kits that vary by contents depending on like what kind of supplies we buy. But just a couple logistic stuff about Cric. If you're right-handed, you should be on the right side of the patient. If you're left-handed, you should be on the left side of the patient. Are you left-handed or right-handed?
Right-handed.
Right-handed. So Ezra will swap with me. The second thing, or third thing, I don't know what I'm up to now, is that we're trying to establish like a go, no-go criteria. So if Ezra and I were on a call and we said, hey, we're not bagging this patient very well, the jaw is rigid, we're not doing RSI, maybe we will someday, but I'm not getting effective ventilation, what's our cutoff to where we're going to Cric this guy? Is it when he loses responsiveness? Is it when the SpO2 falls below 85% or 80%? Is it when the heart rate goes above 120 or the heart rate falls below 60? Is it when there has to be some sort of tangible, you snap your finger, you hit the mark, and you pull the trigger and you go. Not,
well, I know we said 80%, but it's 79%. And I think if I just do this one thing real quick, and if you just give me a couple seconds,
so just like come up with a realistic go, no-go criteria. An unrealistic go, no-go would be like 90%. That might be like the best SpO2 you can get, even if you do Cric the patient. So 90% may be an inappropriate go, no-go criteria, but 75% or 80% or like unresponsiveness certainly would be. Living patients will probably bleed. And then one thing on the video that I've gone over a couple times before is they did this. So there's this concept of a laryngeal handshake, and this mannequin doesn't really simulate it that well. But skin moves this way, left and right, and skin also moves up and down. So you have to like stabilize this membrane, similar to how you stabilize an IV when you cut it. But the problem is your patient may be moving a little bit, and the pharynx might be going up and down as the patient struggles to breathe. When patients are having a tough time breathing, and you're even considering a Cric, there's no patient that you're doing a Cric on that's not having a tough time breathing for one reason or the other. So it's likely that they're going to be using accessory muscles and having a lot of effort breathing. This patient's likely, like their neck muscles are going to be pulling, their upper chest muscles are going to be pulling, their larynx is going to be moving up and down more than it normally would. They may be swallowing a disproportionate amount of secretions. So I think if the patient's like actually working or I don't want to use the term guppy breathing, but kind of, you're going to have more movement in this area than you normally would a normal breathing patient who could hold their breath for 30 seconds, no problem. So this structure is probably going to move. And the skin around it is what you really have to stabilize. And my recommendation is to stabilize that skin like this, left and right. And then everything else is a blind procedure, theoretically. In the video, the guy cut a little bit to the left, and so he had to kind of poke him this way to the right with his finger to find the cricothyroid opening. That increases the risk of false tracking because he had to go under the layer of skin to get to the... You shouldn't have to go under a layer of skin. You should go through an opening that you created. Granted, you can't see it because it's blind. You're going to feel it, but you shouldn't have to go around a layer of skin. You should have to just go down in. I will say one of the things about using a bougie, is that they're smaller and they're more elastic than an endotracheal tube is. So the odds that you false track with a smaller object are greater. The smaller the object you use to go into the area, the greater the likelihood that you could false track it because there's less resistance with a smaller object. The last thing I'll say about my preferences with this stuff is I prefer to not use a Cric hook. It comes with a kit, and if you prefer to use a Cric hook, by all means, if you use it on the bottom or the top, whatever, I don't know. I just think if you can find the anatomical opening to hook the Cric kit there, you have identified where the opening is. So why would you need a Cric hook if you've already identified where the opening is with your finger or a bougie or the tube itself? So I think you increase the risk of perforating the cuff on the endotracheal tube when you insert it. You increase the risk of only tugging on the skin and not the actual tracheal structures, and you increase the risk of poking your finger. So I have never used a Cric hook, and I'm not going to. But if you swear by them and you can successfully do it, then I'm not going to tell you one way or the other. That's just my personal preference. And
I agree. I was going to say I agree. I also prefer to not use a Cric hook. I've seen them used well. I don't think there's a problem with them inherently. But I also think if you're able to use your finger and add an additional sense of confirmation of feel of the hole, why would you remove that by switching your finger for an inanimate object? I don't know. Just makes sense to me to not.
Yeah.
Ready to get after it?
I think so. Yeah, maybe. So I'm just going to prepare. Realistically, for your preparation, you should just get a BVM with a PEEP valve and attach an end title to it before you cut the neck. So we're going to assume... Well, we're not going to assume it's already over there from my video yesterday, although I didn't have the right end title attachment, but we're going to assume that end title is connected to this. End title, BVM, PEEP valve. And then I'm just going to get some gauze. Honestly, a washcloth would probably work. You could get blood and then just coordinate this with your partner if you are bleeding. Don't just leave it there. That's not going to do anything. You might have to press or wipe away. You might just have to clean and dab a little bit, but that's a case-by-case type of ordeal. If you cut straight and not off to the side, you're only going to get tissue bleeding. If you cut off to the side a little too much, that's when you risk going near those smaller veins. I don't really think it's common to cut an artery, but it might be. You could definitely cut through a vein, and then you could get this consistent leak of blood. Okay, I think we're ready to get after it.
So for this, I would probably, again, if they're having difficulty breathing, this might be difficult, but try and lay the patient flat. Maybe even pat under the shoulders. Try and get a nice extension on the neck. I like to feel from the bottom up and find the cricoid cartilage, move up to the cricothyroid membrane, and then above that is your thyroid cartilage, which is the big one. You can also go down from the thyroid cartilage.
And that's the way that I do it, so to each their own.
Yep. Find your spot, palpate, clean in these beautiful concentric circles.
Yeah.
This point, make sure that you have all of your things. So I have my ET tube.
Notice it's Providine, iodine, not alcohol pad. This is infectious inducing, so use this. Sorry.
And then from here, I'm gonna, like Mickey said, stabilize with my middle and thumb, and then so that I can palpate with my pointer finger. Take my scalpel,
Nice gloves. We have gloves.
Yes, and I'm wearing gloves. And multiple cuts is fine. You're cutting down. Follow in. I can feel my hole here with my fingers.
Oh, did you already cut the hole?
Cut the hole. Oh, no, I did not poke the holes. I just slashed down.
All right, so we'll make one more deliberate cut into the membrane.
So, yeah, when you're in there, you can take your scalpel and turn it sideways, and then twist it 180 and cut the other way as well.
And you may have to re-find this landmark if the patient has spontaneously breathed and the structure moved. You may have to
actually struggling.
Occasionally go in there and re-find your landmark and make a couple of cuts.
Yeah.
But a little bit more than necessary cuts is better than having too egregious of a first-time cut and causing a lot of damage.
Yeah, and it does not have to be one slice through. Cutting down is fine. From there, ideally maintaining my finger in it the whole time. Again, like Mickey said, if you lose it, just go back in. I'm going to follow that in with my bougie. Ideally, I can feel it on the rings of the trachea.
Yep. And we're not too far. How far do you think above the carina do you think we actually are in centimeters from this point?
In centimeters, 4, 5.
Yeah, that's probably 4 to 6, something like that would be my guess for a normal-sized adult male. For the Cric kits that do come with bougies, yeah, turns out that that's the largest ET cuff size that you can fit over an adult bougie. Any smaller than that, you have to use a PEDS bougie. Yep.
Honestly, it wouldn't be a bad idea to have a PEDS bougie in here.
Yeah, but the Crics that come with the kits, or sorry, the bougies that come with the kits, if there are, granted we didn't lube this, which would have made it easier.
Certainly.
And we're just going until the black mark goes below
just past the cuff, because you really don't need it any deeper.
Mm-hmm. But the kits that come with bougies, the bougies are usually smaller. And now Ezra's job, or if he wants to transfer that job to somebody else, but some person's full-time job is to hold this in place and do the respiratory thing. So if an imaginary holder is now present, really all that's left to do is
gummy texture there.
Is assess things. Now, if the patient's breathing spontaneously through this and they just need pressure support,
I mean, theoretically, if your issue was an upper airway obstruction, you may not even need pressure support.
Right. But I maybe putting on a vent circuit with a Zoll vent and some sort of pressure support would be beneficial because you can use. I had resistance with him earlier. I think it's because he's not on. He's not turned on.
I'm having absolute
resistance. So anyways, I think putting them on a ventilator on some sort of spontaneous mode, if they are spontaneously breathing with pressure support, you could at least deliver 100% FiO2 as this like recovery phase type of thing. And then we have our, where'd it go? Where's the restrainer? I've actually never used it.
It's over here. Me neither. It looks like.
I wonder.
Put this over.
Yeah. And this should be a 2-person job, honestly.
Yeah, I'm imagining someone is holding the ET2 manually.
Yeah.
During this time.
And you could probably, can we say the term jerry rig? Is that appropriate? I don't know.
Honestly, I would tape this.
Yeah, so we could probably just tape it. You could probably use 3-inch tape and tape the crap out of it, honestly. You could probably wrap tape around here and then yeah.
Again.
So we're learning together because I've never used this.
Here?
Sure. Yeah, sure. I might tape that junction. I don't know if that's correct, but it seems to be working. Yeah. Maybe. But either way, I would definitely put some like strong tape around this.
Let's just do the old.
I don't know. I don't 100% know if that's correct, but whatever.
What I would do is like tape around this and then one direction and the same thing the other direction.
Yep. Mm-hmm.
And realistically, whoever's bagging or just have someone hold it.
We can kind of assess this, or if you have a cuffmometer?
Mm-hmm.
Yeah. Smegmammometer.
Mm-hmm.
Okay. And then if this was a respiratory patient, you might have to do, this falls under the category of post-intubation sedation. So you're ketamine, fentanyl, standing orders apply for this type of situation as well. Because if hypoxia was the issue and you rectified it, and then an improvement in their GCS followed, as is common when fixing the underlying cause, like the H's and T's, then that person didn't get criked over there. This person did.
If you were to use the hook after you cut down, located with your finger, you could then remove this. Get your hook in. Like Mickey said, you could either do it below or above.
I think it's supposed to be above, isn't it? And then you pull it up.
Sure.
That way the tube slides on the non-poke sharp part of it. But either way,
or bougie off the bottom.
Yeah.
Get that like that.
But you should be able to get an endotracheal tube in using just blind insertion in your finger. But I think the best way to probably do it is to use a bougie. If there's blood that bleeds from around the subcutaneous area and then goes into the trachea, it may cause like a light lubricated area in the trachea, which might make it difficult for you to actually feel the tactile sensation of the Cric rings. Yeah. Or if the patient has blood and that's the reason that you criked them to begin with, is because they had a lot of maxillofacial trauma. Any secretions that coat the lining of the inside of the trachea will act as a cushion, so there you might not actually feel the sensation. And the larger the patient is, and the more subcutaneous fat they have, and the shorter their neck is, the higher the likelihood you have to false track it. But there should not be resistance when you push the cuff in. The exception to that is if there was a low foreign body airway obstruction that we didn't know about, and that's what kind of caused everything, and then you hit that foreign body airway obstruction. But I mean, at that freaking point, I don't know.
What are you gonna do?
Good luck. Yeah, what are you gonna do? So cool.